Hi, Year 12. So this is Friday's lesson. If you're using the PowerPoint, you'll see I've kind of marked it out. I think it's slide 24 or something like that, but you'll see clearly where Friday's lesson begins. So as promised, we are kind of concluding the phobias part of our psychopathology topic by evaluating how well those treatments that we've been looking at, the systematic desensitization and the flooding, how well they work. And I'm going to be introducing you to a little bit of a toolkit, I suppose we would call it, for how you evaluate a treatment. And that will come in handy and help us when we move on next year and we're looking at things like schizophrenia. We can use our same treatments evaluation toolkit to look at how effective the treatments for that are. So we'll keep coming back to our treatment evaluation toolkit. So before we plough on any further, your retrieval, just on a blank piece of paper, I want you to retrieve as much as you possibly can about the case of little Albert. So who did it? What did it involve? What were the steps? As much as you possibly can, all of the key terminology. So just pause the video and just go for it. Okay. So hopefully you had a go at that. And I just thought in terms of you checking and ticking off what you remembered, it'd be useful to show you this again. So in terms of who did it, Watson and Rayner, we often just attribute it to Watson because he did a lot of further follow-up studies. So Watson's the key name to remember. You might have remembered a kind of time frame. And these were the steps that we looked at last time. So hopefully you remembered as many of those steps as possible, including some of the key language, so like the fact that at the very end he generalized his fears or his phobia, and that often happens. This is a principle of classical conditioning, and that as Albert was exposed to the neutral stimulus and it became the conditioned stimulus, we saw that conditioned response of being fearful of the white rat, even though originally it was just the loud noise. So hopefully you got lots of that key terminology in there as well. All right then, so we're moving on and we are thinking about evaluating. Before we can do that, there's one extra little piece of knowledge that I kind of want to share with you because it's going to help us with a bit more sophisticated evaluation. With both systematic desensitization and flooding, there is a slight difference in terms of how it can be done. And it very much depends on the phobia. So we can do it in real life exposure, where we, in systematic desensitization, let's use my example of my phobia of rats. In real life, I am gradually, systematically exposed to the different levels on my anxiety hierarchy. If it's real life exposure, if they're actually putting a rat close to me, which gets my heart going, we call it in vivo. If it's not appropriate, maybe not safe or possible to do it with real life exposure, they use imaginary exposure. And that kind of links to that extra reading article that I gave you in Wednesday's lesson, where they're now using virtual reality more. And that's in vitro, imaginary exposure. And sometimes that's necessary because it might not be safe or possible to actually do it for real. And that applies to both systematic desensitization and also flooding. So it can be either in vivo or in vitro. And those are a couple of terms that are worth learning and remembering. You might decide to create a flashcard out of it. And at the bottom there, just a couple of prompt questions. So which do you think would be most effective? Do you think it's more effective to actually be gradually, or in the case of flooding, extremely and immediately exposed to it in real life, or in imaginary? I would imagine most of you are saying, I hope, I have to imagine, I have to hear, I hope that you're all responding to me, that actually real life exposure is going to be more effective. And it is, where it's possible, it is. But actually there's advantages to the in vitro. It's safer. It allows us to use these techniques on things which are harmful to a human being, and it's less traumatic. So one of the downsides we're going to look at, one of the negative evaluation points for flooding, is it's so traumatic that people often don't follow it through. They often have to withdraw from the treatment halfway through. Well, actually, when you're doing in vitro, imaginary exposure, it's less traumatic. But then we could say it's less effective. So that's just worth thinking about, that slight difference, because that sort of thing impresses the examiner when you can distinguish between in vivo and in vitro. Okay, so let's think about some evaluations. Whenever we are evaluating a treatment, there's a number of things we have to think about. So I've just done little icons there, and I'll continue to use those little icons to sort of trigger as little memory cues. We need to think about, what are the relapse rates? And by relapse, and in the grey box at the bottom right-hand side there, it tells us what we mean by relapse rates. The proportion of patients whose symptoms will reappear. Now, that might be months or even years later. But what we need to do when we're evaluating how useful a treatment is we need to say, yeah, but in how many of those patients did they get bad again? Did the disease, the illness, the phobia, whatever it might be we're talking about, in how many cases did it come back? So really, when we're thinking about relapse rates, we're thinking about how long lasting is the effect of this treatment. We have to think about cost. Now, it's rarely the cost to the individual, because most of these treatments will be funded on the NHS. But we need to think about that wider cost to the economy. Does it allow the person to keep working and therefore they're contributing to the economy? Is it very costly to the NHS? If it's not effective and yet loads of money's being spent on it, then it's actually a massive burden to the NHS. So we do have to think about cost. We have to, of course, think about the side effects. If somebody says to you, take this drug, you want to know, well, what side effects am I going to experience? The same can apply to some of the other treatments that we're going to think about. And even if it hasn't got any side effects as such, physical side effects, there might be other negative consequences that we need to think about. Is it really traumatic? Is it going to stop me from doing something? My everyday life, my everyday activities. So we have to just generally think about, what are the dangers with this treatment? Is it effective? Does it work? And is it generalizable? Is it going to work for or be suitable for all patients who have this problem? And is it going to work for all types of this problem? So in our case, phobias. Is it going to work for somebody with a social phobia, with agoraphobia, or is it only going to work with specific phobias? Another key term that I'm going to introduce you to is this attrition rates. This is the proportion of patients who will drop out before the treatment is finished. So sometimes a patient will find flooding so traumatic, even though they only have to have one session, that session's 2 to 3 hours, they just can't cope. They literally will run away from it. Then we say it's got a high attrition rate, it's got a high dropout rate. And obviously it's not going to be effective if you don't follow it through. In fact, you're probably going to leave with your phobia and your anxiety levels much, much higher. Then it's a waste of time and money, which has an impact over here as well with our economy. So it's a balancing act of when we are deciding how good a treatment is, we have to think about all of these things, and a treatment is likely to be good in some areas and not so good in others. And actually, if you think about it, you would want to know most of those things. If somebody said to you, okay, you've come to me as a therapist or as a doctor and you want this treatment, this is what I suggest, you would want to know, well, is it going to work for me? And is it going to last a long time? Or are my symptoms going to come back? And what are the side effects? You probably wouldn't be too concerned about the cost to the economy, the wider economy, but somebody has to be. So all of these things are essentially our evaluation toolkit. Okay, essentially, I need you to start committing those things to memory. The icons might help you, but it means when you then get faced with a question where it's asking you to evaluate a treatment, you know what you're including. Okay, so with that in mind, I have presented some of the evaluation points that are in your online textbook, but also a little bit of a few extras in there as well in that form. So you can see them side by side, so it allows you to make a bit of a comparison. We've got our systematic desensitization and our flooding. Under each of those categories, each of those evaluation areas, we're saying, well, how good are they? Okay. And obviously you can print that out and you can read through that in your own time. I'm not going to read it to you while it's there on the screen, but I think there's a couple of things I would draw your attention to. First of all, at the very bottom, now I've put it under systematic desensitization, but actually we think it could happen with flooding as well. And it's this idea of symptom substitution. Now, I said could because there's very little evidence of this, and there's been very little sort of further studies to investigate it. But what we found in a small number of patients is when they've had one of these treatments, could be flooding, could be systematic desensitization, they're over their phobia of, let's say, it's snakes, but they later develop a phobia of something else. So it's almost like they've substituted one phobia for another. So it's not really solving a problem. And we think that that might occur, but there is very little evidence, and you'd need to recognise that if you were using that as an evaluation point in a question. We know that because systematic desensitisation is far less traumatic, we have fewer people saying no to it. We have a lower attrition rate, so lower dropout rate, and yet it is effective. And the relapse rates are low. Most people that have this treatment and see it through, even when we go back months or years later, their anxiety levels towards the thing that they were afraid of, phobic of, are very low. And there's a couple of studies that have included, like Gilroy there and Rothbaum there, which support that. Always good to have that supporting evidence, isn't it? That's why I've included a couple of studies. And we know because it's less traumatic and it's more systematic, it actually works better for patients that might also have a learning difficulty. If you were to use something like flooding with someone with a learning difficulty, it just would be a disaster because they wouldn't understand what was happening. They wouldn't be able to give their full consent, and it would just be so traumatic, and they wouldn't even understand the purpose of that trauma. So we have to think about that issue of sometimes our patients will also have other complex issues, and what is the right treatment for them, and that comes down to that idea of generalizability. Is it suitable for all patients or just for some? We think now that actually some phobias, the more complex phobias like social phobias and agoraphobia, the ones which are seen as separate categories in the DSM, they're far more complex, and we think probably more cognitive, more about irrational thoughts, more about what's going on in there rather than a learned response. So actually, either of these behavioural treatments are not going to be as effective for those phobias which have a more complex nature and more cognitive nature. And that's a weakness of all of this, isn't it? All of this is behavioural. Well, we know that phobias have a cognitive element too. There's things going on in here when somebody's having those irrational thoughts and that selective attention towards the thing that they're phobic of. But generally, this approach ignores all of that. And that would be a nice evaluation point. So I would say, pause this video, take some time, print that out, read through it, highlight it, because essentially that is your evaluation of both flooding and systematic desensitization. But I'm going to move on, and I'm just going to see how we might apply this. So here's an example of a question. This is in your packs, your exam question packs that you've got for each topic. So this is in your psychopathology pack. So we've got Tommy. So we know we pick apart the item and we really look for the clues and where are the hints. And it was part B of that question that I wanted you to see. So you can see, it's only 2 marks, but so you can see how you might need to use this information. Explain why systematic desensitization might be more ethical for Tommy than flooding. So what we need to do is we need to think about this bottom row here. This is a sort of ethics. Well, what are the negative side effects? How much trauma is he likely to experience? And we just need to apply that to the case of Tommy and talk about those levels of anxiety. So that's just really a demonstration of how we might need to use this information. What I'm going to ask you to do now is think about how we might apply this in a longer question, a 16-mark question. Now, don't panic. I know you've not long done one for me, and some of you are struggling to kind of catch up. That's fine. I'm not going to ask you to do this as an essay. All I'm going to ask you to do is, as an exercise to get our head around this knowledge and evaluation, I'm going to ask you to turn it into a plan. So we're almost working backwards, because what I've done is I've found a question and I've found what the mark scheme says. So we can see we've got our outline, our possible AO1 content listed, and our possible AO3 or evaluation content listed. Now, there'll be things and studies referred to that you haven't covered. You can't cover every study. I've used different ones to what they have, so I don't want you should panic about that. But you can get a general feel of what sort of knowledge and content they would expect you to include. You can see the detail there, in vivo or in vitro. We're using the proper language. We're talking about exposure. We're talking about the relaxation techniques and so on. What I want you to do is take that, alongside that, taking the kind of the key evaluation points, and produce a plan. So, and it is just a plan. That is the only thing I want. And so I've broken it down like I have done for you before. We know it's 16 marks. We know 6 of those marks are going to come from knowledge, AO1, 10 from AO3. So because it's kept it quite general and it said behavioural treatments, to allow ourselves a breadth in our answer, I would choose 2, and I would do the 2 that we spent all this time looking at, flooding and systematic desensitisation. So I would want to have 1P paragraph on flooding and 1 on systematic desensitisation, where I am just outlining, I'm just showing my knowledge. This is what it is. This is how it works. We're putting that detail in it. How many sessions would I need to have? How long would the sessions last? What would it involve? We're using the language, but we're just showing our knowledge. And then for our evaluation, it's exactly the same principle as in all other essays. We need to think, okay, we're getting roughly 5 marks for evaluating flooding, roughly 5 marks for evaluating systematic desensitisation. I want to aim for 2 evaluation paragraphs on both. So I'm going to have 2 evaluation paragraphs on flooding and 2 on systematic desensitisation. And for my 2, I'm going to use that PL structure, making sure I link back. Why does it matter? Why is it useful? Why is it a problem? Always my link back is important. And I'm going to pick any 2 of those to focus on. I might focus on the negative side effects, the trauma of flooding. I might focus on the cost effectiveness of systematic desensitisation. It's totally up to you. You take 2 of those for flooding, you take 2 of those for systematic desensitisation, you use your PEAL structure, and that would be it. So I'm not asking you to write it, I'm just asking you to plan it using that structure. So just literally, I'll see on your piece of paper, PEE, or for the evaluation, PEEL. You're not writing it up fully, okay? So essentially, that's it. Plan only, reminder, because I know I don't want panic to set in. Essentially, that's it for this lesson. It's got you thinking about evaluating. We've got used to this new evaluation toolkit that's applicable to treatments. So you might want to go back to the flashcards that you created before, and you might want to add on a couple of strengths and weaknesses of them, or you might want to create a flashcard for the different elements of that toolkit. Get used to those icons, because I'm going to be using them regularly whenever we come across a treatment and we're getting ourselves to think about how to evaluate. That's it. So that's the week's lessons concluded. Well done to all of those, to you all, for keeping up and keep going. I know this is really, really tough. Next week, we'll be moving on after a little bit of review and just checking that we're all okay and that we're good with our knowledge so far, but we will be moving on to look at our next disorder, which is depression. Okay, so you've got that to look forward to. All right, take care, year 12. Bye.